Now, acute leukemia, so we have acute lymphoblastic leukemia, acute myeloid leukemia, it's most common malignancy in children, peak incidence 2 to 5 years of age. 80% of acute leukemia during childhood are lymphoblastic, and it's more common in male. Acute myeloid leukemia, so peak incidence 65 years, and they are more common in adult. In adult, 80% are myelogenous leukemias. What are the causes? So acute lymphoblastic, we have prior bone marrow damage, adult T cell leukemia linked to human T cell lymphotropic virus, genetic or chromosomal factors. Then we have acute myeloid leukemia. In acute myeloid leukemia, we have pre-existing hematologic disorders, most common cause. Then we have environmental factors like chemo, ionizing radiation, benzene, tobacco, and genetic or chromosomal factors. Down syndrome, so the risk of AML is like that of ALL 10 to 20 times higher in patients with Down syndrome. And also phenconemia is also a cause of leukemia. Classification of the ALL, so we have French American British classification FAB, in which L1 includes small cells 20 to 30%, L2 heterogeneous large cell which is 70%, and L3 is large cell, for example Burkitt lymphoma. Then we have WHO classification, and then we have immunophenotype classification of ALL based on the origin and the maturity of the leukemic cells. On the basis of this, we have B cell ALL, which are the most common, 80 to 85% of cases, and we have T cell ALL, which accounts for 15 to 20%. Further, B cell are early or pro-BLL, common ALL, precursor BLL, and mature BLL, also known as Burkitt lymphoma leukemias. Then we have T cell ALL, 15 to 20% of the cases. We have early ALL, we have intermediate ALL, and we have mature T cell ALL. AML, so we have 5 classifications which have 8 different subtypes. M3 we have acute promyelocytic leukemia, M5 acute monocytic leukemia, M6 we have erythroid leukemia, and M7 we have megakaryocytic leukemia. While M1, M0, M1 and M2 these are myeloblastic leukemia. M0 is without maturation, M1 with minimal maturation, and M2 with granulocyte maturation. Then we have WHO classifications. So these are AML with recurrent genetic abnormality, AML with myelodysplasia, therapy-related AML not otherwise specified, myeloid sarcoma, and myeloid leukemia associated with Down syndrome. Pathophysiology, so somatic mutations which are chromosomal translocation and other genetic abnormality in early hematopoietic precursors. So there will be clonal proliferation of lymphoid or myeloid stem cell line and arrest in cell differentiation and maturation. So they cannot mature into the functional leukocytes. The rapid proliferation of abnormal and dysfunctional blasts with impaired apoptotic pathways. So accumulation of leukemic white cell in the marrow disrupted normal hematopoiesis. So there will be leukemia, due to which there will be increased risk of infection, thrombocytopenia, increased risk of bleeding, and there will be decreased RBC leading to anemia. They can infiltrate other organs as well, particularly CNS, testes, liver, and skin. The new clinical features. So clinical features are either related to marrow failure, infiltration of the organs by leukemic cell, or combination. These are the general features of acute leukemia. So there will be sudden onset of symptom and rapid progression. There will be anemia, thrombocytopenia, and leukopenia leading to increased risk of frequent infection and fever. There will be hepatosplenomegaly caused by leukemic infiltration. Hepatosplenomegaly is more common in ALL. It occurs in greater than 60% of individuals, while 10% with AML. Oncologic emergency can be the first sign of leukemia. For example, elderly patient presenting with priapism or DIC may have leukostasis, more common in AML than ALL. So oncologic emergencies are more common with AML, while hepatosplenomegaly is most common with ALL. Now we have the features of ALL. So these are fever, night sweats, weight loss, painless lymphadenopathy, bone pain, airway obstruction like stridor, difficulty breathing due to mediastinal or thymic infiltration, primarily in T cell ALL. Features of superior vena cava syndrome, meningeal leukemia or leukemic meningitis, headache, neck stiffness, visual field changes, or other CNS symptom caused by CNS involvement. and we will have testicular enlargement, but it's a rare finding. Then AML, we have leukemia cutis or myeloid sarcoma. These are nodular skin lesions with a purple or gray-blue colors. So this is the presentation of leukemia cutis. These are the purple nodules. Then we will have gingival hyperplasia, myeloblasts infiltrating the mucosa. Signs of CNS involvement, headache, visual field changes. Fever and lymphadenopathy are common first signs in ALL, while they are rare in AML. Fever in patients with acute leukemia must always be treated as a sign of infection until proven otherwise. Now we have diagnostic approach. So initial evaluation, suspect leukemia in patient, suggestive of clinical or lab features, confirm the diagnosis with a morphological assessment. Further diagnosis studies, so we have immunophenotyping, we have cytogenetics, and molecular genetic testing should be obtained in order to identify the subtypes of acute leukemia. Initial studies, so we have lab studies, CBC with smear. Leukocyte count may be elevated, normal or low, and is not a reliable diagnostic marker. WC count may be normal, elevated or low in patient with acute leukemia, but the WC will be immature and non-functional. Platelets typically mild to severe thrombocytopenia, and hemoglobin, so will have typically anemia. These are the blast cells. Intermediate sized blast with dispersed chromatin, moderate amount of cytoplasm, and indistinct nuclei are seen alongside pale stained erythrocytes. Smear, so there will be presence of blasts. In acute leukemia, remember there will be blast on the smear, which are immature WBCs. And we can also do liver chemistry and renal function test, comprehensive metabolic panel. So we have often abnormal due to increased cell lysis leading to tumor lysis syndrome. The findings usually are hyponatremia or hypernatremia, usually hyperkalemia, hypercalcemia, and hyperphosphatemia, increased LDH and increased uric acid. Coagulation studies, so mild coagulopathy may be present. Now the confirmatory studies, so in ALL we will have greater than 20% of lymphoblasts, small to intermediate size blasts, blast with large irregular nuclei, high nuclear to cytoplasmic ratio, inconspicuous nuclei which are not clearly seen, coarse granules, and no AR rods. While in AML we will have large blasts, 2 to 4 times the size of an RBC, blast with round or kidney-shaped nuclei that contain more cytoplasm than blast in ALL, prominent nucleoli, fine granules, while here we have coarse granules. Leukemic hiatus. Leukemic hiatus is the presence of blasts and mature leukocyte, but no intermediate form like myelocytes, metamyelocytes, promyelocytes. So we have blast and mature form. This is known as leukemia hiatus. Some subtypes, especially M3 or acute promyelocytic leukemia, exhibit AR rods. So we have AR rods in AML while there are no AR rods in ALL. These are the pink red rod-shaped granular cytoplasmic inclusion body in malignant immature myeloblasts or promyelocytes. And myeloid leukemias are also MPO positive. So these are the myeloblasts with rod-shaped inclusions known as AR rods. Cell morphology can confirm the diagnosis, but in most cases it is necessary to complete immunophenotype and genetic study before selecting a treatment. Specialized studies, so these are further categorize the cell type involved. Some characteristics may be associated with better response to certain therapies. Immunophenotype and genetic studies, so finding in ALL and AML. Immunophenotype, we have immunohistochemistry, so these are MPO negative, but these are TDT positive. And also they are PAS positive, periodic acid shift. They are MPO positive but negative for TDT and PAS. Then on flow cytometry in B-ALL is usually positive for CD10, marker for immature B lymphocytes, pre-B cells. CD19 and CD20, these are the markers for B-ALL. T-ALL is usually positive for CD8, CD2 to CD8, but especially CD3. So AML is positive for CD13, 33, 34, and CD117 and HLA-DR. Genetic studies, cytogenetics, so Philadelphia translocation present in 20 to 30% with ALL, but only 5% of children with ALL. In adults, it about 20 to 30%. Philadelphia translocation is more common in CML chronic myeloid leukemia than acute. It is a common finding in older patients with ALL, with a prevalence of up to 50% in patients greater than 50 years of age. Then we have childhood BALL, in which translocation 1221 is most common, and then trisomy 4 and 10 associated with good prognosis. Hyperplasia is common in pre-B cell ALL. In AML, especially acute promyelocytic APL, we have translocation 15 to 17, which is a subtype of AML M3 AML, and Philadelphia translocation is rare. Then we have molecular testing, so these are the findings in ALL and these are the findings in AML. Myelogenous leukemia are positive for myeloperoxidase, so they are MPO positive. Screening for extramedullary disease, so CNS infiltration is common in ALL. Perform LP and obtain CSF flow cytometry. Consider brain, spine, CT or MRI. Testicular infiltration relatively common in ALL. So testicular ultrasound is done. Thymic infiltration primarily in T-cell ALL. Consider CT may show mediastinal mass. Hepatosplenic infiltration, abdominal CT or ultrasound, and other form of diseases of extramedullary, so consider PET CT and or lymph node biopsy. All patients with ALL should undergo screening for CNS infiltration. CNS and testicular infiltration are common in ALL. Now treatment. So in treatment we have pre-treatment assessment, then we have chemotherapy. In chemo we have systemics, and it's decided on the individual patient and disease factor. Intrathecal commonly used. Consider adding for patient are at high risk of CNS infiltration. All patients with ALL, targeted chemo, consider adding for leukemia with specific immunophenotype and genetic profile, for example, Philadelphia translocation. We have other adjunctive treatment, radiation, immunotherapy, stem cell transplantation, supportive care, and management of complications. Early and aggressive chemo improve the prognosis. Example, 80 to 90% of patients with ALL achieve complete remission with chemo. We have systemic chemo, so here we have induction therapy, which average duration with ALL is 4 to 8 weeks. Then we have consolidation, which is about 4 to 8 months, and maintenance therapy, which is about 2 to 3 years. Here are the common agents used in the treatment in ALL. We have alkylating agent, anthracycline, antimetabolites, enzyme therapy, alkaloids, drugs. In AML, we have anthracycline, antimetabolites, and hypomethylating agents. In acute promyelocytic leukemia, we give all trans-retinoic acids and arsenic trioxides, and chemo with anthracycline like edarobicin. In APL, the 1517 translocation and subsequent formation of the fusion gene can inhibit myeloblast differentiation under physiological level of retinoic acid. So high doses of retinoic acid are required to induce myeloblast differentiation and promote remission. Management of CNS infiltration. So intrathecal chemo here is triple therapy with methotrexate, cytarabine, and hydrocortisones directly into subarachnoid space. Indication in ALL, prevention of meningitis, while in indication in AML are treatment of patient with confirmed infiltration, prevention in patient with high risk APL, and CNS radio consider direct radiation alongside chemo in selected patients. Then we have advanced therapy. So in advanced therapy, we have targeted therapy like tyrosine kinase inhibitor and Philadelphia chromosome positive patients, PCR, ABL, tyrosine kinase inhibitors like imatinib, ponatinib, and then we have midostaurin and FLT3 type of AML. Autologous or allogeneic stem cell transplantation is indicated in patients who do not achieve remission with chemo or in patients with poor prognostic factors. Management of complications. When we have management of complications, so oncologic emergency like tumor lysis syndrome, management we give fluids and rasparicase, while in prophylaxis we can consider hydration and urate lowering therapy like allopurinol or rasparicase. But in management we give rasparicase. Leukostasis we can consider fluid and cytoreductive therapy. Management of treatment-related complications. So for anemia, thrombocytopenia, neutropenia, we can give granulocyte colony stimulating factor like filgrastim and consider antimicrobial prophylaxis until resolution of neutropenia.